We are going to begin our plenary talks now. The plenary talks are going to be from the Asia Pacific Academy of Ophthalmology, and I would request Dr. Clement Tam, Dr. Tetsuro Shika, Dr. Kenneth Fong to please come on the dais, and along with that, the awardees, Dr. Rajwardhan Azad, Dr. R.D. Ravindran, and Dr. Charles McGee. Please, can you all take up the seats on the dais? So the first plenary talk is going to be the Jose Rizal Medal, and the Jose Rizal Medal recognizes an outstanding ophthalmologist annually for his excellence in ophthalmology in the Asia-Pacific region. And this medal was instituted to commemorate Dr. Jose Rizal, an ophthalmologist who became a national hero of the Philippines. It is my privilege and my pleasure to welcome the awardee, Professor Charles McGee, who needs no introduction. He's professor and chair, University of Auckland since 1999, founder and director of New Zealand National Eye Centre. He's amongst the top 10 most influential ophthalmologists, according to the Ophthalmologist UK, one of the 20 icons shaping modern ophthalmology as per the APAO, Vice President of the Academia Ophthalmologica Internationalis, member International Intraocular Implant Club, President of Academy of Asia-Pacific Professors of Ophthalmology, past President and Honorary Life President of the British Society of Refractive Surgery, which he co-founded, past President of APAO, as well as Australia, New Zealand Cornea Society. He has made key contributions to CLASIC standardization. To his credit, he has 1,815 research outputs, including 500 papers and 3 textbooks, and he's secured research funding, which runs into millions. He has been honored as Officer of the New Zealand Order of Merit, honored by Queen Elizabeth II. He's going to be talking about the etiology, diagnosis, and management of keratoconus, understanding the contemporary evidence base and dispelling 170 years of misconception. Dr. Charles McGee, please.
Thank you. It's a great pleasure to be here today and to present the Jose Rizal Medal Lecture. I have no conflicts of interest. Jose Rizal was a famous ophthalmologist and pioneer who sacrificed his life for his beliefs, and I follow a tradition of many speakers since Dio Campo. So what I'm going to talk about is keratoconus, and I'm going to cover over 5 main areas, starting with the landmark paper of Nottingham in 1854. So if we look at the evidence base and consider misconceptions, there are several different levels of evidence. The top levels being largely meta-analysis of RCTs and prospective studies, and the least good evidence being level 5. So what would Sherlock Holmes make of this? The fictional detective was born in 1854 in Nottingham's paper, but he probably said expert opinion is the least reliable evidence, so some of what I say you may want to disregard. If we look at the evidence base, it's growing rapidly. In fact, there are more than 10,000 papers on keratoconus, and of these, the vast majority have occurred in the last 20 years. So what do we know? We know there are genetic and environmental causes. We know it probably is a non-inflammatory disease, but we'll discuss that more. It's a progressive corneal ectasia. There's increasing irregular astigmatism with visual loss. The end stage is high drops and scarring, and treatment includes transplantation and collagen cross-linking, but as yet, there is no cure. So I'm going to look at how we refine the diagnosis, mainly by a number of new developments. There's also the classic things we looked at, including astigmatism and refraction, scissoring, retinoscopy, reflex, and Munson sign and down gaze. We also look at slit lamp appearance with the classic signs here from some of my patients, including thinning and ectasia, Fox striae, Fleischer's iron ring, Rizzuti's sign, prominent corneal nerves, Descemet's tear, and of course, near bottom right, severe eye drops. Computerized corneal topography completely changed the way we look at keratoconus and other corneal diseases. A number of new indices occurred in the early 1990s, such as central corneal steepening, asymmetric inferior steepening, and asymmetry of central power, largely from Rabinowitz's group. In subsequent studies, we found that 50% of relatives of those with keratoconus probably have abnormal indices and astigmatism. We further look in high prevalence groups and we find that maybe perhaps 1 in 5 relatives are suspected to have keratoconus. Computerized corneal topography is involved into tomography, so three-dimensional imaging. So we've moved from placebo into Scheimpflug fluke and OCT modalities. These increasingly identify early disease. They're key in refractive surgery. They enable better keratoconus classification and reveal family abnormalities, as we've mentioned. These can calibrate disease progression, enable prognosis, and provide monitoring treatment of treatments such as CXL. Tomography versus topography, well, slit scanning techniques win out because they also add in the third dimension of pachymetry and posterior elevation, as demonstrated in this study looking at suspect cases by Donald Tan's group. There are a number of indices. I'm not going to go into those in detail, but the Bell and Ambrosi enhanced ectasia display, the BAD indices, are very useful. This looks at a number of parameters, puts them together and integrates that data in an AI fashion. What about repeatability? We've got these devices, but can we use them in a widespread fashion? Well, we looked at 50 eyes of 50 subjects with keratoconus, and we found that the number of devices were actually quite disparate in what they measured, but they were internally consistent with high repeatability. So the bottom line is, if you're using an instrument to measure keratoconus, you should use the same instrument in the same patient all the time. Newer modalities include biomechanical assessments, such as those by ORA and Corvus ST. These are very pretty instruments that tell us an awful lot about the actual function of the cornea and have allowed us to develop new indices, but they cannot actually discriminate subtle keratoconus from the healthy normal eye. So although these biomechanical tools help us understand keratoconus, they remain very much in the research realm rather than currently being a key clinical tool. Will artificial intelligence solve all our problems? Well, if you read the popular press, you would believe that. Artificial intelligence refers to the capability of computer systems to perform tasks that typically require human intelligence, such as learning, reasoning, problem solving, and decision making. This was written by an AI device 5 days ago. Will this solve the problem of diagnosing subclinical keratoconus? Possibly not yet. This Cochrane study looked at 54 articles evaluating detection of manifest keratoconus using other utilities. AI was pretty good, with a high sensitivity and specificity in the region of 98%, but accuracy varied, and the certainty of the evidence was low. 28 articles evaluated subclinical keratoconus. There was good accuracy, but the sensitivity was 90%, meaning 1 in 10 cases we missed. Quite a problem if you're screening for refractive surgery. And the certainty of evidence was very low. So the authors concluded we weren't able to draw clear and reliable conclusions due to the high risk of bias, and particularly the unexplained heterogeneity of the results. In Cochrane Corner, we et al. Made a couple of observations. From keratoconus detection to innovative approaches in predicting disease progression and monitoring of risk factor, AI demonstrates immense potential to enhance keratoconus management. However, the present review highlights that the current landscape of AI research is marked by inadequate reporting and methodological limitations. So what about etiology? What have we learned over the last 171 years? I'll cover over these 3 areas. It's almost certainly multifactorial. It may in fact be the final common pathway for a number of different pathological processes. One of the variables is definitely genetic, and there are also several suspected environmental components. These integrate into a simple two-hit hypothesis. You have a genetic predisposition, you have an environmental second factor which brings it out. This is why we have such a varied prevalence of keratoconus, varying from 8.8 to more than 50 per 100,000 in the larger established studies. In studies where we look at topography, it may be 1 in 30 have suspicious topography. And this variation in part is due to different diagnostic criteria, differing genetic predisposition, and differing exposure to cofactors. If we look around the world in this blurred map, we find that the average might be somewhere between 50 and 100. New Zealand has 50. But other areas have quite low counts, like Japan, 8.8. Whereas other centers have enormous levels, such as Iran and India, which may be partly affected by consanguinity. And other areas that are emerging with data still not fully established. In this study by our team, we looked at keratoconus over 24 months in New Zealand. We looked at almost 2,000 cases of a mean age of about 41. We found that the ethnicities were European, Maori, and Pacifica, but Maori and Pacifica were overrepresented compared to Europeans. Mostly, 2/3 were managed by contact lenses, and mean corrected visual acuity was good at 6.9. But Maori and Pacific pupils had the highest mean K and the highest, most severely affected eyes. So other than ethnic predispositions, what are the other inherited and systemic associations? Well, the common ones we should all know are Down syndrome, Marfan syndrome, Ehlers-Danlos syndrome, mitral valve prolapse, and Leber congenital amaurosis. A number of these are associated with eye rubbing. Therefore, we've looked at a number of genes, including those on trisomy, on chromosome 21. Candidate suspects include all these listed here, including 2 collagen genes, but none of these have actually been convicted as being a general cause. Why is that? Well, if we look at the first large-scale genome-wide association, the GWAS, of keratoconus, this looked at 4,500 cases and more than 100,000 controls. 36 loci were suspicious. Both dysregulation of corneal collagen matrix integrity and also cell differentiation pathways were identified as disease-causing mechanisms. Pleiotropy suggested that there may be common mechanisms affecting other corneal diseases, and we all know the association with Fuchs and keratoconus. Common keratoconus variants only explain about 12.5% of the genetic variants. But there is the potential for future diagnostic tests, but not currently. So in summary, in terms of the genetics, it's complex. It's way above my grade. The genetics are not Mendelian, but polygenic. The family history increases your risk 6-fold. There's concordance in severity for monozygotic compared to dizygotic twins. Large studies have identified very many associations. Many loci are genes associated with biomechanical elements. Polygenic risk scores can be generated to give odds ratio. In the future, this may allow us to assess patients in terms of the longer-term risk. But getting back to misconceptions and old wives' tales, a widely held traditional belief that is now thought to be unscientific or incorrect. And this might have been Mrs. Nottingham speaking to her friend in 1854. Did you know that apparently eye rubbing can make you blind? When I was a registrar, I did not believe eye rubbing caused keratoconus or really had any role. I thought it was an old wives' tale. However, things change. We should all change. And at this study by Crawford et al., we looked at a number of factors. Obviously, ethnicity and consanguinity, we've already mentioned, are important for geographical variations, but also 4 key areas: eye rubbing, atopy, floppy eye syndrome, and contact lens wear are strongly associated with keratoconus, less so, but linked, pregnancy and thyroid dysfunction. These first four factors actually induce ocular surface inflammation, and matrix metalloproteinases can be released, and this may produce keratocyte apoptosis, which I'll come back to. So Rabinowitz has looked at the genetics of various other factors, and he agrees on the genetic plus corneal mechanical effects, and actually states that the proposed mechanical trauma, such as eye rubbing, is a sine qua non for the onset of keratoconus, and quite possibly its only cause. So we image corneal microstructure in a number of ways, both in the lab and clinically by in vivo confocal microscopy. We find that the loss of cells is non-inflammatory. This suggests apoptosis as the mechanism in keratoconus. In a study by Nidra and our group, we looked at basal epithelium, anterior keratocytes, posterior keratocytes, and endothelial layers in a large number of keratoconics, and found the cell count was reduced in all layers. Also, the subbasal nerve plexus is reduced by about 50%. If we look at the nerve plexus, we find it's both abnormal in density and also in shape. If we take away the background information and look at the nerves and then superimpose them on a corneal power map, we find that the cone itself may be dictating some of that fragility and loss of the subbasal nerve plexus. And the loss of keratocytes is what makes the nerves more visible. Trevor Sherwin from Auckland reports that the results support the evidence for inflammatory pathway activation in keratoconus and a possible redefinition of keratoconus as a chronic inflammatory rather than non-inflammatory disease. If we look at this another way, look at epidemiological studies to identify associations between keratoconus and immune-mediated diseases. This is a large study, 2,000 keratoconics, more than 12,000 matched controls. It confirmed some novel associations, such as Hashimoto's thyroiditis, inflammatory skin conditions. It also confirmed known A to B associations, including allergic rash, asthma, allergic rhinitis. The authors recently concluded keratoconus appears positively associated with multiple immune-mediated diseases. Therefore, systemic inflammatory responses may influence the onset of keratoconus. How can we put this together in a cell basis or molecular biology way? Well, what about cell signaling? Epithelium is traumatized and releases interleukin-1. Keratocytes have receptors for IL-1 that are 4 times greater than normal keratocytes. This releases more Fas ligand. Epithelial trauma also releases Fas ligand. This Fas ligand is also picked up by those binding keratocytes. And what do we get? We get apoptosis, or cell death, throughout the cornea. So in the last 5 minutes, I'm going to talk about the management of keratoconus under these layers. So what do we think we know? It usually commences in late puberty. It's a gradual or intermittent progression. It's stabilized in 40s. About 20% need transplant. Maybe some misconceptions there. Indeed, if we look at children, this is a large study of 100 patients aged 15. We find that progression occurred in 77% over a 3-year period. The eyes progressed in more advanced disease at presentation, and importantly, there was a higher rate of bilateral progression if at least one eye had severe disease at presentation. What about older patients, though? Well, this is a CLEC study. The mean coverage for 8 years had increased by 1.6, but look behind the data, and we find that 24% had a 3 diopter change. That's significant, especially when the baseline age was 40. In this study, Aki Goko looked at the natural history of corneal topography in adults that had never worn contact lenses, only worn spectacles, were well corrected and had relatively mild disease. They were about 40. About a quarter showed some changes in 4 indices, but less than 10% and more than a diopter per year change. So even in these low-risk cases, keratoconus continues to progress. In this study, we looked at 100 eyes with end-stage eye drops, and what did we find? We found that Pacific, but not Maori, are more commonly affected than Europeans. It occurred approximately 4 years after the diagnosis. There was a strong history of eye rubbing, but actually a negative history of family involvement. In a third of the cases, surprisingly, in a country with free healthcare, the patients had never seen an eye doctor or an optometrist. So what about the treatment options? Well, these are listed here, and most of them will be familiar to you, from conservative to more aggressive. In an early study we performed, we found that about 2/3 of patients are maintained in contact lenses, about 1/3 gone to penetrating keratoplasty, usually about 8 or 9 years after diagnosis. However, that changed a lot with the advent of corneal cross-linking. As Wallensack said in 2006, is this a new hope? Although the Cochrane cross-linking review in 2015 was less admiring, saying the evidence is limited due to lack of properly conducted RCTs, it did notice it had been adopted worldwide. If we look at a more recent review from our team, we concluded that the modifications of the original Dresden protocol work well. Accelerated protocols have shown comparative results, and although there are limited studies, it would appear that immediate sequential bilateral cross-linking is pretty safe. Generally, it's very well accepted, and the success rate in most studies is better than 90%. Of course, intracorneal segments are used in a limited fashion in eyes which have reasonable vision. It's safe with femtosecond lasers and can be combined with CXL. In terms of transplantation in Auckland and in New Zealand has always been heavily influenced by keratoconus. But if we look at the data since we introduced cross-linking in 2007, allowing there would be about an 8-year lag to see major changes, we found an immense drop in this study in the number of cases requiring corneal transplantation for keratoconus. Keratoconics generally do well with grafting, with a 90% survival at 10 years in low-risk cases, but the main failure is rejection. Of course, we do have a panacea for that, and that is DALK. The disadvantage is technically more challenging and may have financial issues in some centers, but the major advantage is preserving the endothelium and avoiding allograft rejection. However, this has not been adopted as widely as one might have expected. There are emerging studies, which I'm not going to get into detail, which include CARES, intrastromal lenticule insertion, and Bowman's layer transplant. But I'd like to finish in the last 30 seconds or so looking to the bright new future and summarizing somewhat of what we have learned in this lecture. After 170 years, there's still no cure for keratoconus. Its genetics are complex, non-Mendelian, and only partly explain the disease. A two-hit hypothesis best fits with genetic plus environmental factors. Possible inflammatory elements may be there, and therefore atopy and eye rubbing should be treated. Tomography, OCT, IVCM, and biomechanics improve our understanding and diagnosis, but subclinical early cases still defy 100% diagnosis. AI has great potential, but it's not yet a diagnostic panacea. Contact lenses remain the mainstay of treatment. Cross-linking in its several forms typically stabilizes keratoconus now. Penetrating and DALK are still foreseen to be needed for the foreseeable future. Gene therapy is highly unlikely, but genetic diagnosis may highlight susceptibility to KC and therefore consideration of environmental factors. Cell therapy trials only number 3 and are still in their infancy. Only remains for me to thank the many, many individuals who have been involved in this research over 30 years and to the National Eye Bank of New Zealand, which provided much of this data. Thank you very much for this kind invitation, and thank you for your attention.
Thank you so much, Dr. Charles Magee, for that phenomenal contribution in keratoconus and your excellent plenary talk. It is a pleasure again to introduce the next talk, that is the Holmes Lecture. The Holmes Lecture is the highest award for exceptional contributions to preventive ophthalmology, especially in the prevention of blindness in the Asia-Pacific region. The Holmes Lecture is named in memory of Dr. William J. Holmes, the founding Secretary General of Asia-Pacific Academy of Ophthalmology. It is my pleasure and honor to introduce the Holmes Lecture awardee, Dr. R.D. Ravindran, Chairman, Arvind Eye Care System, who's looking after 14 hospitals and 120 centers, former CMO, who's led 4 hospital expansions, pioneered 200+ annual outreach camps for underdeserved communities, established 5 telemedicine eye centers for rural care, trained more than 100 residents and more than 200 fellows, led major blindness studies such as Arvind Survey, INDEYE, and RAP Survey, a government advisor to NPCB, NABH, and Vision 2020, and regional co-chair for the IAPP from 2004 to 2012. To his credit, he has more than 90 publications and more than 30 awards and named orations. Over to Dr. R.D.R. Ravindran for his talk on improving cataract surgical quality through monitoring and benchmarking, an important journey.
Yeah. Thanks, Dr. Namata. So good morning, everybody. At the outset, I would like to thank all the office bearers of APAO for honoring me with this lecture, which is named in memory of Dr. William J. Holmes, who was one of the founding members of APAO in the year when it was started in 1960, and he was also the founding Secretary General of APAO at that point of time. And for this lecture, I have chosen the topic, the journey of improving cataract surgical quality through monitoring and benchmarking in our organization. And the Aravind Eye hospitals, I just want to give a brief background because we have several international delegates. So it was started by Dr. G. Venkatsamy in the year 1976. It has grown into a network of 14 hospitals, 8 community eye clinics, and 117 primary eye care centers. And the year 2023-24, the financial year, we had seen about 6 million outpatients, and we have performed about 700,000 plus surgical procedures, which also includes about 448,000 cataract surgical procedures. And over the last 50 years, we have done about 10 million procedures, and 50% of that is free or subsidized care. And all this has been possible because of the trust the patients have on the organization. And I can attribute to 2 things. One is the patient-centered approach and our attention to the quality in the patient care part. And if you want to understand the quality, what it means, it is also good for the staff of the organization, any hospital to understand, is that it has got 6 elements as put forth by the Institute of Medicine in America. The 6 elements are the safety, patient-centered care, effectiveness, efficiency, the timeliness of the care we provide, and also the equity. And for today's talk, I'm going to talk about the safety and the effectiveness part of it. And the patient safety is the base for quality, and we are all aware, that patient safety is about treating the correct patient, correct site, the correct treatment, and not harming the patient. Especially in our context, it is about preventing sight-threatening complications. And in the part about improving patient safety, I'm going to touch upon how do we minimize safety errors in our practice. How do we minimize glow perforation in anesthesia? The third part is about how do we minimize post-operative endophthalmitis. So the safety errors is something which we don't talk about much in our meetings. The incidence of safety error in the hospitals around New York, there was a publication in the year 2007 titled Surgical Confusions in Ophthalmology. There they talk about wrong IOL implants, wrong eye surgery, wrong eye block, wrong procedures happening in about 62 cases out of 900,000 procedures which were done over a period of 6 years. And they are all reported to a local organization, which works out to about 1 per 15,000 procedures. And they also go on to say that nearly 85% of this could have been prevented if the safety protocols have been followed. There is a recent paper in 2018, JAMA Network, which looks at the incorrect procedures which happen in the Veteran Hospital Administration, which is a large chain of network of hospitals across America. They looked at 8-year data of about 3.23 million surgical procedures, not just ophthalmology, but all specialties. And they found there were about 277 incorrect procedures, and they also prevented 206 close calls. This 277 included about 90 wrong side procedures, about 86 wrong implants, many of which were ophthalmology related, and wrong side, for example, operating on a wrong vertebra or on a tooth. So these are all not high volume, these are all low volume centers. Even there you have incidents, the sentinel events happening. And it has affected all these surgical specialties, as you can see. But you can see on the top is ophthalmology with 72, nearly 25% of these incidents happened there. While other surgical specialties, it was 1 per 20,000. In ophthalmology, it is about 1 in 10,000. And here again, performing a comprehensive timeout probably could have avoided many of these errors. And all of us, all our practices, whatever be our size, we always have come across something going wrong. Because the safety errors in eye care is very prevalent because we have bilateral organs, it's a high volume specialty, and we have to take multiple measurements where no documentation errors can happen. There are also multiple team members can be involved, and we have a fair share, large number of patients who are vulnerable patients, who are hard of hearing, they have dementia, mentally challenged, and very old patients. So to that, I'm in this context, when you already have so much of complexity, in Aravind in a day, we handle about, especially I've taken an example of Aravind Eye Hospital, Madurai for this talk. We handle about 3,500 plus patients on a daily basis. We do about 700 surgical procedures. And that is done by about 200 surgeons assisted by 1,000 plus allied health personnel. And the most important thing is that each patient is touched at least by 10 to 12 ophthalmic personnel in the organization. So it is not uncommon that in the year 2012, of the 146,000 surgeries and other procedures we had about 23 errors, which accounts to about 1 per 6,500 patients, even though none of these patients lost vision and some of them may had a resurgery. But still, it is important that we have to prevent such errors in our practice. So we had taken up to understand what really causes. We really understood when we look into these issues, we found that it is not the people who deliver the final care or not the people, which we call it as acute failure. Everything has been done very well. The people who have done previously have done a good job, but the surgeon who's doing it or somebody who's giving an anesthetic block fails. So it is always because of the lack of safety culture. When I say that, it is absence of formal protocols and processes to ensure safety. It is also non-adherence to the protocol, and sometimes all are there, documentation errors happens and lack of communication. So it's only the policy, process, and the technology, not the people. When these are involved, policy and process, technology, then it is about, we call it system failure, and nearly it accounts for 90% of the errors in most of the places. So we adopted several processes, which I'll go through one by one. But the first part is we had an awareness meeting amongst all our hospitals to understand what goes wrong in our hospital. We discussed all the errors. That was sometime in 2011 and 12. And we also introduced an online reporting form, which is available and is anonymous reporting. Once we introduced that, people reported what goes wrong, not necessarily safety, but related to patient centeredness, efficiency, effectiveness, all of that. And we are also able to clarify the safety goals for the organization. We clarified about 10 different goals. Actually, this talk, I'm only talking about the goal 1 and the goal 2 part, and also the goal 4, which is about preventing hospital-acquired infections, and goal 5, which is sight-threatening complications. And we had developed standard protocols for 16 different areas, developing Word documents, policy documents, PowerPoint presentations for training, posters and videos, so that everybody is aware of that and everybody is involved. But the underlying theme is it's all about correct patient identification, either in outpatient clinic or in an inpatient clinic. And it's all about eye marking to make sure that the correct eye is operated. And one of the issues we used to have is wrong eye block, anesthetic block. So we made sure that there was an allied ophthalmic personnel or ophthalmic technician or nurse will stand with the doctor when the anesthetic block is given. When we did that, it completely went away. Very often, this is something is done by the doctor alone. And instead of having a timeout only in the operating room, we had timeout at least in 2 other locations to make sure that all the documents, everything is in the case sheet or there, and all investigations, including biometry, have been done. The intraocular lens is available. So we make sure that the organization, the surgical procedures also go on very efficiently. So I'm just sharing for the last year, I showed you that in 2012, we had 23 errors, 1 in 6,500. In the year COVID, our volumes dropped significantly. We probably saw about 40% of the surgeries. And there it went down, which was 1 in 6,500 has become 1 in 37,000. We just had 2 errors. But the next year, the volume picked up, almost became double, and we also, the number of errors also increased, and it became 1 in 23,000. And the year 2022, we had 189,000 procedures with 5 errors, which is 1 in 37,000. In 2023, it was 1 in 47,000. And last year, for the very first time, we did not have any error, in spite of the volume we had. And and it's all been possible only because of the involvement of the staff and the culture we were able to build, and we hope to continue to maintain this in the coming years. So what we have done to prevent the safety errors is we have identified areas where errors happen in our practice. We understood how they happen. The root cause, understanding why it happens, how it happens, only then you can come up with a proper solution. So we also created independent checks for key processes. A doctor advises, for example, a patient, a right eye, left eye surgery. The next person who sees the patient, who's a counselor, has to ask an open-ended question to understand the doctor has done the job correctly. She will also check whether the surgical advice is also correct. So creating this culture by involving multiple people and creating safety teams becomes very, very important. The second part of this patient safety is about minimizing globe perforation. The globe perforation ophthalmic anesthesia varies anywhere from 6 to 130 per 100,000. These are all from the literature. In Aravind Hospital in Madurai, from 2013 to 2015, in the 3 years, we had done about 289,000 surgeries, and we had about 13 globe perforation, which is about 4 per 100,000. And subsequent year, we completely transitioned because we understood from NHS that they have completely moved to us subtenon to minimize this complication. When we did that, from 2000 onwards, 17 onwards, the anesthesia-related perforation completely went away, which means we had prevented 92 potential perforation. When you have a perforation, nearly 50% of these patients have very poor outcome. The third part is how do we minimizing the post-operative endophthalmitis. So like any other organization, we put a lot of focus on sterilization, disinfection protocol until 2014. And during that period, our infection rate used to be 7 to 8 cases per 10,000 cataract surgeries. And in the year 2014, we adopted intracameral moxifloxacin. Dr. David Chang was one person who really pushed us into adopting intracameral. We did a pilot in the hospital Madurai, and then we scaled it across all the hospitals. And we also published, after adopting it across all hospitals, we had published about 600,000 surgeries, what has happened. And when we switched over, the incidence dropped from 7 or 8 per 10,000 to 1 or 2 per 10,000. It was actually phacoemulsification. It was just 1 per 10,000, and small incision is about 1 per 20,000. And still we continue to have the incidence below 2 per 10,000. And this means in 2024, we have prevented 257 potential endophthalmitis compared to the rates we had in 2014. So just to summarize, the outcomes of safety measure is So when you have a safety protocol, it also improves the communication between the caregivers and the patient, which improves the patient trust. The staff also have a better clarity of their job. The incident reporting, we are able to detect the problems earlier and also address it. When you don't have sentinel events like globe perforation, endophthalmitis, you also have a much better work atmosphere. The second part of my talk is about effectiveness, which is about how do you minimize the complication, how do you maximize the visual outcomes. And we had created a cataract surgical outcome monitoring called CATQA, where earlier we used to have a manual data entry. Now we have a real-time data entry from the EMR. And the surgical outcome the monitoring parameters include the preoperative data, the surgical data, post-operative, follow-up, and endophthalmitis. The surgical, the important one is we track the intraoperative complication. Post-operatively, we track the resurgeries, and follow-up, we look at the follow-up, uncorrected vision, best corrected vision, and also the follow-up compliance. So this is what a doctor will be able to see every month after the follow-up visit is over. The doctor gets a mail, and they'll be able to access the software, and they'll be able to see all the parameters. They're in the different sections: the paying section, free section, camp section, the pre-op, intra-op, post-op, follow-up, and also we look at the biometry part as well. So we using this, what do we do with this data? We have weekly complication review meeting. We review every patient. This happens every week. We review every patient who had a surgical complication. We review every patient who had a post-op complication, who had a resurgery, and the patient who came back with an infection. And again, overall post-operative visual outcome. And the thing is whether it was managed well, what is the outcome, who managed it, is there anything we did not do, what is it we did, we could have done to prevent this complication happening as well. And based on what we learned, we also segregated all our pre-op patients into 3 groups. A normal group, a group we called as a complex, which includes high myopia, hypermetropia, small pupil, angle closure suspects, post-keratoplasty. And then we have a high-risk group, which includes cataracts following post-VR surgery, post-radial keratotomy, patient who got a nanophthalmus, or patient had a subluxated lens, or a nanophthalmic eye. And we also had created a provision in the EMR to mark this group so that we are able to take good care of these patients. And again, we also put a lot of focus on training our residents and fellows. The numbers of that varies anywhere between 170 to 200 people. We have to really train them well. We use the OSCAR scoring as well. And again, we also have an option to benchmark. I can benchmark myself with a surgeon who does maybe like 1,000+ surgery. The hospitals can benchmark themselves. So that option is also available. We also track the accuracy of biometry because it's very important for the uncorrected visual acuity. So this is the data for the 2024. And then the spherical equivalent within 0.5 diopter is around 93%. And again, for each individual biometrist, also this is tracked so that we are able to keep the quality. And this was published, a 7-year trend in cataract surgery indicator quality outcomes. So we looked at about 1.86 million case records from the year 2012 to 2018. And of the 577,000 phacoemulsification procedures done across 10 hospitals, so we didn't take the hospitals which were recently started. The complication rate dropped from 1.3% in 2012 to 0.7% in 2018. The reoperation rates, however, remain the same. And again, of the 1.24 million manual small incision cataract surgeries we have done, there is a reduction in the intraoperative complication rate from 1.8% to 1.3%. So I feel whatever steps we have taken has helped over a period of time. And when you have a data and when you act upon that, you'll also be able to make a change. And again, this is a thing that shows the visual acuity outcome. The uncorrected visual acuity of 618 or better, which is the WHO norm, of manual small incision cataract surgery increased from 66% in 2012 to 85% in 2008. You may not see such a clear change in the uncorrected visual acuity of phacoemulsification, but here again we had a statistically significant improvement, even though we may not be able to see that graphically here. And just to summarize, the monitoring has helped us to improve the quality, the sharing of the data and benchmarking between the individual surgeon. With the individual surgeon really made them take their own effort to make things better. We also put a lot of, to improve the visual acuity, the uncorrected visual acuity to make it better. We changed the incision architecture and the wet lab practices, monitoring of the minimal of the surgical training, and also the using the simulators all have helped to minimize the surgical complication. We also tried to see what are the cases. We have a provision to look at what causes, what are the patients who have poor vision and what is the reason for that. Also, we'll be able to track from that. And we also have done work, we also have found some of the IOLs, the A constant was appropriate because the refractive error we get in those patients were very difficult. And again, to conclude, any organization, if it wants to achieve excellence and quality, you have to focus on what goes wrong in the organization. That's very, very important. When you know what is going wrong, you have to find the root cause, and you have to collect the required data, and you have to find evidence-based solutions for improvement. All these are available. Once you are able to get that improvement, then you have to empower the team. So it's not an individual's work. You have to empower the team to implement it and make a change. Thank you.
Thank you so much, Dr. Ravindran, for that phenomenal work again done to improve the quality of the cataract surgery. It is my pleasure and honor to announce the next plenary talk, the APAO ICO Markso Golden Apple Award for the Best Clinical Teacher in Ophthalmology in the Asia-Pacific region. Initiated by the International Council of Ophthalmology and as a token of the ICO's commitment to improving ophthalmic education worldwide, the ICO Mark Tissot Golden Apple Award honors the most dedicated teacher of clinical ophthalmology in the Asia-Pacific region. It is named after Professor Mark O.M. Tissot, former ICO Director of Education. It is my honor and privilege to introduce the speaker of this award, who's also my teacher and mentor, Professor Rajvardhan Azad. He has more than 3 decades of experience in imparting teaching and research in learning principles and practices in ophthalmic education across various universities in India and abroad. He's the founder of the coveted FICO degree that is given by All India Ophthalmological Society. He's also the chairman of Akhand Jyoti Eye Hospital, the former chief of Dr. Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. He was the youngest president of the National Board of Exams. He is currently the Asia Pacific Academy of Ophthalmology Chair for Ophthalmic Education. He has been ICO trustee and AAO advisor. He's the lead investigator in more than 25 trials. He's mentored more than 50 postgraduates in All India Institute of Medical Sciences, authored 12 books, and has to his credit more than 200 publications. He is recipient of 50 named awards, and his talk is going to be on eye to teaching. Over to you, sir.
Thank you. Thank you very much, Namrata, for a very lavish introduction. So I'm really grateful to the ICO and also to APAO for having conferred me with this ICO Markso Golden Apple Award, named after Professor Mark So, who was a former ICO Director of Education. The ICO Golden Apple Award honors the most dedicated teacher of clinical ophthalmology in Asia Pacific region, and that's why I will talk more about the teacher. This is me. My affiliation has already been told by Namrata. The Argentinian proverb is, those who speak, they sow, and those who listen, they reap. So there is a very august gathering is there, and I hope the earlier 2 lectures, you must have reaped something from that. What is an oration? An oration is an introspection into what you have done. And what you have done, that is, if it is narrated, then it becomes an oration. And then the oration should be such that it should get the benefit to the audience, and it should inspire also. So that is what is oration. What is an ophthalmic education? The concept of ophthalmic education is, for that matter, any education, engaging with knowledge, which symbolizes a deep hands-on connection with learning. And it is an active interaction key. The other aspect is the educators. And by this I mean the teachers, the trainers, the professors, the lecturers, the assistant professors, the demonstrators, and everything is included here. And then understanding the spirituality, the philosophy of teaching. What is the philosophy of teaching? The philosophy of teaching is to give. A teacher has to give. He doesn't have to take. He has to update his knowledge, and he has to give. That is the philosophy of teaching, and which represents the wisdom, the enlightenment, or the guidance. Something like, if somebody touches, something like Midas touch. You know Midas touch? There was a king in the Greece, and the king, if whatever he will touch, will become a gold. So that is the touch should be with the teachers. And teaching, whether it is an ophthalmic teaching or education or any education, it is a tripolar process. And by this I mean, one pole is teacher, the second pole is the student, and the third pole is the institution. And I was lucky to have a very good institution, that is RP Center for Ophthalmic Sciences. I'll talk about that later. And also, I had a very enlightened students also. So that way, I was lucky. So who is a good teacher? Who has got a passion for teaching? Teaching is not something, you can acquire. Teaching is something which comes from inside, which is innate quality. And the teacher is one who has empathy, who empathizes, sympathizes with the student. He understands his student. He adapts to the requirement of the audience. If I'm teaching an undergraduate, I should talk at that level. If I'm teaching a postgraduate, I should talk at that level. So adaptability should be there. And the communication skill should have some good communication skill. And encourage critical thinking. If I tell something, it should irritate your, the gray matter of the audience. And he should lead by example. He should be an example to others, then only they will follow you. Build the relationship. There should be a relationship between the student and the residents. And, if somebody says that I know everything, so that is not possible. Knowledge is something which is dynamic. You have to update your knowledge. You have to be a lifelong learner. And last but not least is the self-assessment. When I take the classes, I always think what I have given to the student. When I go back home, I keep on thinking that what I should have given and what I have given. So if there is any disparity or not. So self-assessment is most important. Now I'll put myself in the testing zone. And what I have done, I was president of National Board just now, Namrata said, and lots of things I did, lots of things, big reforms I did. Screening test for foreign medical graduate. First time I started in India. Examiner orientation program. Means the examiner who are going to examine, their knowledge should be updated. updated the accreditation standard. And I was also chairman of postgraduate committee in Medical Council of India, and then many other things which he started. I was in several universities. I was in Gonzalo as a visiting professor, in Toronto, and also in Texas Medical School. Several societies. I was chair, speaker, visiting professor, guest lecturer. Invited lecture, I delivered courses, workshops, so on and so forth. Now I'm chair of the Ophthalmic Education Committee. I was a member on ICO committee on subspecialty education and certification. I'll tell you something here very important, and that is that for the first time in the world, we started the certification for subspecialists, and that is by All India Ophthalmological Society Collegium, what you call as a FAICO. And this was, you know, we had a small collaboration, kind of what you call as a test certification with the ICO for 2 years. I'm basically a retinal surgeon. And my journey started with buckling surgery, and those days only buckling surgery was done. We did so many of buckling surgery, you know. Redo surgery, again redo surgery, put one buckle, then posteriorly one buckle, another posterior buckle. By that time, the vitrectomy hadn't come, and we published these papers. I devised a modified needle drainage, a very simple technique, and just go in the sclera and go inside, and when the fluid comes out in the hub of the needle, and then we draw it. So no cost. Laser came somewhere between 1977 and 84, and we were the first few, maybe 2-3 places in India, and we had argon laser. A lot of these argon laser we did. Vitreous surgery we started in 84, and microscope was in use, and the primitive machines were there. And of course, when you start, you are a novice surgeon. And we published some papers. And then between 1990 and 94, something very, interesting came in my professional life. And I, moved to what? My passion, that is retinopathy of prematurity. And this was the status. 86% babies were referred by ophthalmologists, 8.7% babies referred by pediatricians. Correct diagnosis only by ophthalmologists, 4.3%. You can imagine the awareness among the ophthalmologists. And metropolitan city like Delhi shared out of all the data, 30% of these problems. And 91.3% of the babies were visibly blind. This moved me, and I took up this subject as a passion. We did a lot of these awareness programs with National Program for Control of Blindness, and also with WHO. And we had devised a concept of paired workshop, where we'll have neonatologists also and ophthalmologists also. We had some more of these workshops. And the Sightsaver workshop, 17 workshops in collaboration with Sightsavers India from 2008 to 2012 in various cities of India. And we must have made aware more than 700, maybe 1,000 ophthalmologists at that particular time. And then during this period, I established the screening and management protocol for retinopathy of prematurity at Dr. R.P. Center. So what I say, that if you are a teacher or if you are a trainer, you must give something to the society. You must give something to your student. You must give something to the institution. So we established it there. And I also set up this ROP, Modern VR Surgery Unit in Kuwait. I was there from 1994 to 1988. And during this period, I said, and so many premature children, we examined there. This was not part of my work. I tell you, the working hour in Kuwait is from 7 o'clock to 2 o'clock. And after 2 o'clock, I was free. So I thought, what should I do? So I started doing screening in the afternoon. So that is that. And we made a lot of these publications, intervention at pre-threshold stage of retinopathy of prematurity, regression of retinopathy of prematurity, and all this. And from paper we published from Kuwait also, now the center is known as Al-Bahar Center for Ophthalmic Sciences. And then I promoted ROP in our country. I formed the Indian ROP Society, which is still going from 2016. And then we had a World ROP meeting. 2009, we had in New Delhi, 12 in Shanghai, 23, in between, we had in Cancun, World ROP, and in Dubai, 2023. I joined RP Center as a junior resident in 1974, and I left RP Center, took voluntary retirement, maybe 2 years earlier. Nobody will do that. And I did this for a greater cause, for the social service, and my obligation to the society, and my obligation to my state. And the whole period is how much? From 1974 to 2014 is almost 40 years. So I gave my prime of life to RP Center. And RP Center also gave me a lot of things, not that I just gave. What I am today is because of that. And because of the few of my teachers like Professor L.B. Agarwal, who was there, whose brain was like a computer. He knew if you enter his room, he'll know who is this guy coming and for what he's coming. Professor Madan Mohan, Professor Tiwari, who was my friend, philosopher, and guide, and many other people, who was with me, my friends. So as I told you in the beginning, you have to have the, education is a tripolar process. One is the teacher. I have told you about the teacher and put myself there. And then is the institution, and this is the institution, and many other institutions are there, not this one only. I can only tell you this much, that in 1974, way back in 1974, we had the subspecialty. We had uvea, we had retina, we have cornea, we had glaucoma. I don't think anywhere in India it was there. So that was the kind. We used to use Hochstreit slit lamp those days, Hochstreit slit lamp, you can understand. So most of the things we had during that time. And a lot of research is being done that those days, and now it is also being done. We are also into developing the postgraduate education, in capacity building, in development of new techniques and technology. Lots of our friends are there, and the center is developing lots of new techniques. And those days, we had an eye bank, which was established, including corneal grafting and tissue transplantation. I think there is a video, I think. Can you increase the volume?
Audio is there, so can you put the lead of the audio?
क्या इसका वॉल्यूम बढ़ा दो
academy, and care. The center is a constituent ophthalmic services unit of the All India Institute of Medical Sciences. RP Center is spread across a standalone 7-floor building as 300-bedded facility catering to a footfall of more than 5 lakh patients per year. The center has the largest ophthalmic residency training program in the world, with over 250 ophthalmology residents training in basic and advanced ophthalmology, with 40 several faculties.
I think you will keep the time, that is very important. So, I think I didn't talk anything about the student. And I'm very proud to tell you that many of my students, they are abroad and they are consultant in their own hospital. And I had the privilege to guide more than 70 postgraduate students, which I'm still doing now, for research projects. I was examiner to many universities in India and abroad. And my clinical area of interest, as I told you, is retinopathy of prematurity. My clinical experience, I've screened so many babies and so many training centers I supported. And we have Indian ROP Society where we are offering all kind of help and all kind of support to plan and to work further in this particular area. And training of ophthalmologist. This is already, Namrata has told you about my, the publications and the H-index, published 12 books. First book I presented, published on retinopathy of prematurity, Atlas. And then there is a textbook also of retinopathy of prematurity. First book of Atlas, maybe the first one in the world. This is my father and my mother. They are above. I thank them. And last but not least, my wife, and who bears most of the brunt because I am mostly out and she is at home, and she is responsible for bringing up my child, although they are now very big. I mean, my son is also a retinal surgeon, my daughter is in Singapore, but then it's all because of my wife, and which gives me a lot of time. Each one of us has own story to tell, and some are good to buy, and the others are good to sell. And what is a success? Success is happiness, less and less. Thank you very much for your kind attention.
Thank you so much, sir, for that insightful talk on ophthalmic education. And thank you, everyone, for attending this plenary session. May we have the photograph of the dais, please? And can we all stand up and give a standing ovation to all our orators and the speakers of the plenary session? They deserve a big round of applause for their contributions for last so many years in the field of ophthalmology. May I request Professor APAO ma'am to please come on the dais and join us for the photograph. Dr. Tetsuro Oshika and Dr. David McKay also please join us.